Department of Surgery. I mainly work in the breast center and with Dr. Fodele and Dr. Avoso. So some of you have seen me in the breast center. And just to go over the clinical breast exam, there's, it's pretty straightforward, but they're going to be the person testing you as you walk in. They're just going to be watching you, see what you're doing and what you're saying, too. Because some things they may not catch you doing, but you can always verbalize it, too. So I'll give you credit. I remember there's 10 things that they look for. So I think introducing yourself is one of them. And first of all, your visual inspection. So you want to visualize, like open the drape, or it may be a person there, or it may be just like this model thing in front of you. So you can say, I would open the drape and do the visual inspection. And so remember 3 arm movements, with the arms above the head, with the arms at the side, and with the patient leaning forward. So I always say, ask the patient to raise their arms above their head. They could press down on their hips and lean forward, because pressing down on their hips retracts the pectoralis muscle, and you're basically looking for retraction and things like that. So that's sitting up. With lymph nodes, I palpate lymph nodes sitting up, but I don't know if y'all have seen Dr. Avoso do his lymph nodes. He checks when they're lying down, but as long as you're checking lymph nodes, or you're verbalizing it, that you would check the axillary lymph nodes, you'll get credit. And also the supraclavicular and infraclavicular spaces. Those are the other things. So those, so your visual inspection, patient sitting up, and your lymph nodes, which then after that you can ask the patient to lie back. You may have seen me we do a vertical sweep, like against the chest wall with the patient sitting up. You're not tested on that. That's just a special little thing that Dr. Fodele taught me to do. The idea of that is if it's a deep lesion on the chest wall, once the patient's supine, the breast will cover it up in some cases. So that's a little extra that we do. But you shouldn't. It's kind of awkward palpating the breast with the patient sitting up, so you might as well just have them lie down. We do have I have an article about the clinical breast exam in the clinic too, if y'all are interested. So supine, what they're looking for is a systematic palpation of the 4 quadrants. So either if you use the vertical stripe pattern or the circular pattern, that's up to you. Even the old textbook says to use 1 hand. I use 2 hands. 2 hands are usually better than 1, so you can vary your palpation as you go. But even if you're doing 1 hand, it looks kind of awkward because you're not doing it with the other hand, but you're welcome to do that too. As long as you're palpating all 4 quadrants. And then don't forget to palpate both breasts, because then you'll be deducted if you don't go around and palpate the other. And don't forget about the nipple. Palpate the nipple, as you're going along, palpating, just go right over, but make sure you squeeze the nipple. And they don't really test you on like how hard you're squeezing or how light you're squeezing, so you can just stay and check the nipple drainage. I usually do like 2, like one way and then another way. But don't forget positioning with the patient supine, that you would have the patient place their arm above their head. It's not always a person in front of you, and the models don't have arms, so you don't even think of that sometimes. That's like the main thing that some students will forget. They would totally forget about stating that they would have the patient place their arm above their head. You don't have to be all fancy with the pillow and all that behind, just as long as the patient's arm is above their head. Any questions? Okay.
Do we have to instruct the patients on how to do their own clinical breast exam?
The self-exam, that's fine for your own purposes, but it's not on that sheet that they're talking. I mean, it's a good practice, too, to do it. Sometimes, patients are, the student is just talking to this, y'all get nervous and you're just talking and improvising, but that's fine, if it helps get you through it. There'll be a little paper, a little sheet of paper to put your physical exam findings on, but you don't talk with the person watching you do the clinical breast exam. That's for like after you turn that in after the ASCII, at the end of the ASCII. Yeah.
How long should it take?
A good exam, like I would say like 2 minutes. Well, they say 2 minutes per breast. I mean, I think you get 5 to 7 minutes. I think you get 7 minutes per station. I mean, it's plenty of time, especially if you're starting out with the whole arm movement. That takes time.
It's actually 6.
It's 6 minutes, yeah.
They'll have 6 for the test, the exam, and then they'll go do a post-test, which is on the computer after they leave the room, and that's 6 minutes. So altogether it's 12, but 6 for the actual examination.
Yeah, rarely do I see students run out of time doing it. But just if you practice either at home or in your mind, your systematic way, just anytime you do a physical exam on any patient, always do it the same. That way you don't forget anything. You don't miss out.
Are we supposed to verbalize after like what our findings to the patient?
No.
No, not at all.
You can just say, we found a lump. I'm going to discuss these findings with the attending. Students say all sorts of things and they walk up. So the person testing you in the room is not going to mark down. You're just going to mark on that little sheet. So.
What's the post-test on? Is it on the actual procedure? Is it asking questions about how to do a breast exam, or is it case-based questions? What is the post-test on?
It may ask you your findings, to note your findings. And what about, tell them, do they need to put on, you don't wear gloves. I know it's a sterile technique when you walk in the room and you introduce yourself. Make sure you speak up. Say your name, and if you have a number, you're going to say your name and your number. I'm not sure if you have a number, but make sure you say your name when you walk in. If you don't have anybody in there to speak to, let's say, for example, it's the proctor, you still speak when you walk in the room, because that's just practice, and it's,
Now, in the past, this one's really, really old,
yes.
but there has been a patient, a person holding this with the drape over them. And so you're palpating this, and
on their chest.
Yeah, on their chest. So that has happened before too. But yeah, anything else?
This is the time to ask questions, because after this is it. And then you'll just practice coming in the room.
Sorry, so you said it may be a person holding that, or it may just be that on the table?
Yeah, it could be. One that we've used before is a model kind of like this, but it's like on a little stand, a little kickstand. So you can kind of just improvise, like the patient sitting up, and then put it down, and the patient supine.
Okay. So you don't think there'll be someone holding that against them?
It could be, unless they got a new model, and that's similar to this, where they can use a real person. If there is a real person, don't kill their underarms. Don't be really, because we had one old lady one time, and she would be so sore at the end of the day from students pushing up in her axilla. But, do you have a question? Especially if it's a model, not a person, you can improvise how you would hold the arm and check the axillary and lymph nodes. There should be enough room in the clavicular space, so the infra and supraclavicular spaces to check. So they'll be watching you, the person that's testing you.
Okay, and what you're gonna come back after Dr. Passy finishes his teaching conference. She's gonna come back and she's gonna demonstrate how to insert a Foley.
Yeah.
Okay.
All right.
Okay. Thank you.
Thank you.